just to say thank you to Tim for doing this webinar for all of us.
No problem.
Thank you very much. It's always a great pleasure to have Tim on board, and especially with this subject, which is I know he likes a lot, and is pure osteopathy.
Yeah.
So yeah. We will have questions, as Pindy was saying. If you want to chat any questions, I will drop those questions to Tim to answer. And okay, so I think Sean says he's ready.
Okay.
If we have some problems, I will. Okay, so please, Tim, you can start now. Thank you.
Okay, welcome everybody. This is kind of like a little bit of a summary, although I've got quite a few slides to run through on a presentation I did a few years ago, 2016 in Berlin, at a conference on autonomic nervous system and trauma. And the subject I brought up was basically relating to the autonomic nervous system in the context of treating a case study or patient I was working with at the time and still do. I'm working currently as well. My interest in developing interest in multiple sclerosis and how we can actually start to work within the context of the autonomic nervous system as it was the actual subject matter then. So I'm going to continue. I just basically consolidated a few slides, added a few bits and pieces to it. May seem a little bit chaotic, but the gist is that I brought the whole presentation across as like a multi-systems approach, because I didn't want to just say, here is the general body adjustment or general osteopathic treatment, because, you know, that's perceived in many different ways by so many different people, and quite often it's considered just to be purely, you know, a biomechanical or a MSK-based approach for mobilization. And I wanted to go into more detail, so I deliberately left out that term and brought in the concepts of how we're dealing with the various systems that are involved in multiple sclerosis and how we deal with the symptom patterns, and also, most importantly, you know, work within the context of trying to see whether we can actually improve the quality of life value and various parameters that we'll include in the presentation today. So this is what we're going to go through. Excuse me if I have some problems with these things, because my keyboard's a bit funny at the moment, and we've got a lot of temperature here like you have everywhere in Europe, and I do believe there's going to be a thunderstorm soon, so hopefully we don't have any power outage. But anyway, we'll continue. So what I'm going to look at is we're going to actually look at developing a wellness program. This particular article that I discovered or looked on was kind of like the precursor to my pathway for developing the ideas of how we might go approaching MS in the context of our work as osteopaths. So we're going to go generally through multiple sclerosis, general information. I'm going to zipping through I'm going to go through the autonomic nervous system really quickly, some considerations. You've all got background in this, but what becomes interesting is how we're actually kind of like addressing the nature of those specific landmarks in the context of our treatment, and how we can potentially influence various components of the autonomic nervous system in relationship to different regions of the body, and in the context of integration too. So we're going to look at that, and then we're going to look at actually the case study itself, looking at the actual presenting considerations, and also the content of the profile of the patient in relation to the autonomic system, and how we're dealing with interfacing with that in treatment, and how we're actually going to look at evaluation of treatment outcomes. There's many listed treatment outcomes for MS, as amongst other degenerative conditions, and we're going to look into a few of those too. And we're going to look at some existing samples of some research that's been done. It's not extensive, just a few that I've picked up on. And what I'll do as usual is I will produce, as I always like to do, is like a resource page for this. So you will better contact the Institute, and they'll better pull some nice papers down, or links to papers that relate to some of this documentation. So I'm going to skip through a few pages and go into the actual nitty-gritty of things in a while. I'm going to refer above me because I've got a copy of this document on my other big screen, because unfortunately I can't get my notes running at the same time with this presentation. I don't know how to do it yet. So let's have a go. Let's have a look at this. So let's think of osteopathic. One approach to management of MS may favor that which is a multi-systems nature. So we're looking at the effective systems that are involved with it. And of course, we're looking at the idea that within all concepts of osteopathy, we're looking at body unity, the human being as a dynamic unit of function. And this is, the glossary of osteopathic terminology from ECOP. So let's have a look at that in some more detail. I want to have a look at this whole idea, flipping through this at speed, but you'll have reference to this anyway, materials relating to this anyway. But let's have a look at, how we effectively look at this idea of wellness and how we can deal with developing a potential wellness program. So again, this could be multidisciplinary in terms of you working with other healthcare professionals or other colleagues or other therapy types, but it also incorporates a whole mechanism of a multi-systems approach as well, when we look at it in some context as well. So, this is one paper that I came across at the beginning, many, many years ago, and it just looked at the way in which a particular team developed a wellness program incorporating various healthcare providers, and actually looked at developing a multidimensional method of treatment, or addressing the method of treatment during the management of the illness with multidimensional approach. So this kind of brought me to the idea of, well, yeah, that's what effectively we are doing within the context of our treatments too, but within the context of systems as well. So looking at this, let me just see why, with my other reference. Yeah, because multiple sclerosis is a multidimensional chronic disease, effective management of the illness requires a multidisciplinary approach. A wellness program is designed to facilitate positive health choices for the course of MS and present initial data analysis. So they looked at different parameters that they were looking at, and specifically looked at the physical, mental, social, intellectual, and spiritual domains relating to the quality of life and physical functioning and self-efficiency of those patients receiving treatment at the time. And the outcome data was based on very specific types of functional status and fear avoidance beliefs, and various other aspects of evaluation, which are standardized outcome measures that can be addressed. Very interestingly, participants would demonstrate improve in the domain that they were particularly looking at. The wellness program included educational sessions in physical, mental, social, intellectual, and spiritual domains, as we discovered, and try to provide motivation and self-efficiency, physical functioning, coping skills, symptom management, and effectively nutrition aspects of their lifestyle as well. So again, this biopsychosocial model kind of becomes to mind when we're looking at this component as well. And of course, outcome measures, you need to kind of like have some evaluation of data. So a software program was developed where simple parameters according to various outcome measures were collated, and the data formulated and analyzed as most standardized methods are. And when they looked at it, there was significant changes in various values that related to fear avoidance, for example, depression, somatization. Somatization is the experience of communicating physiological distress in the form of somatic symptoms. So quite often looking at those kind of like subtle indications of stress within the patient. So, respiratory change, sweating, anxiety, things like that. And of course, looking at trying to reduce that affective depression and anxiety, going along with that kind of like multi-dimensional aspect of treatment. So they can, if you look at the outcomes, they're relatively good. And this paper is openly available online, but I will provide it again as a resource later on. So this is where I came from. I thought, well, look, where can we how can we start working with this in terms of the symptomology and the symptom patterns that we get? Obviously, within the context of osteopathy, we're not always looking just dealing with addressing symptoms, but typically in MS, we want to try and categorize symptom patterns according to their systems as well. So this is what most people try to look at in terms of that whole idea of the body unity and the holistic aspect of things. So I wanted to just look at this and say that it is this case study we're looking at is an integrative approach for the potential osteopathic treatment of this disorder, including autonomic control, regulation, and function of many systems within the body, and how that relates to typical presenting symptoms of MS involving GIT, GU, respiratory, motor, visual, and balance disturbance, stress, fatigue, influence on anesthetic load, cognitive and emotional well-being of the patient. So some of these I will address. Some of these are work in progress. And this is what I've been working on for the last 2 to 3 years. It's actually kind of like dealing with a group of about 12 to 14 patients and addressing various outcome measures according to their needs and their enthusiasm or interest in what I've been doing in terms of treatments, and also them helping me and me helping them with various parameters to evaluate. And this is becoming very interesting, actually, and had some good results so far. But of course, you know, the ultimate aim is to do a longitudinal study where we can actually look at a cohort group and, you know, implement a certain strategy of treatment, and then look at various outcome parameters and evaluate the longitudinal outcome of that. The means by which we can potentially interface these particular autonomic landmarks and pathways within the domain of our osteopathic treatment. So we're going to talk about that. And, you know, a lot of you guys out there are probably classical osteopaths listening to me, some may not be, but you'll have some context and reference points. And if you look at some of those images above on that little sketch here, you can see some components of that what we relate to, specifically in terms of ventral autonomic interface work, etc. So let's continue. Let's go over MS a little bit, just a little bit, and we're going to just look at various components. You just have to bear with me because I'm trying to get a simplistic interface here. So basically, you know, MS characterized by damage of specific nervous tissue, autoimmune mediated. You get a scenario where you get changes in the gliosis, glial tissue, lesioning of scar tissue called plaques, which we quite frequently see and are evident on weighted MRI or CT type of presentations. And as you look at that diagram below, you'll see it's typical kind of like opaque patches in various regions of the brain and the spinal cord. And this is a typical thing that's presenting. So plaques are typically found in the ventricular system of the brain, which is very interesting, around the optical nerves, in the white matter and optic nerves that are control vision. So you quite often get this associated optic neuritis and visual dysfunction as well, or modification or adaptation. And the white matter of the spinal cord, brainstem, cerebellum, and cerebral area of the brain. So the specific regions that are specifically connected, but this can, you know, be associated with other plaque formations elsewhere. So we get this destruction of myelin effectively affecting the conductivity of the nerves, and of course the signaling processes, and in respect to the functionality of the nerves too, simplistically. Let me just go to the next one. So this is the demographics, prevalence and risk, you know, according to various regions of the world. The figures that I've got are based on 2 or 3 years ago. Multiple Sclerosis Foundation estimated that there are more than 400,000 people in the United States alone, and about 2.5 million people around the world with MS. That's, you know, gently on an increase. Increase of MS is also higher in colder climates. So it's really curious to see how this relationship of climatic incidence is there too. It's not considered an hereditary disorder. However, there may be genetic predispositions to developing the disease. 15% of individuals with MS have one or more family members or relatives who have it, according to the National Institute of Neurological Disorders. In the case of identical twins, there is a 1 in 3 chance of a sibling to have the disease. So, there's also a kind of hypothesis that there's genetic predisposition combined with environmental or viral factors also. So, you know, this whole idea of the way in which the body is beginning to be affected by the potential of autoimmune dysregulation and also autonomic dysregulation to some degree, influencing the symptoms that we're getting. People with autoimmune disease, especially type 1 diabetes, thyroid disease, inflammatory bowel disease, are slightly increased risk of developing MS, but, you know, that's just general observations. And research also indicates the relationship between MS and infections such as Epstein-Barr, herpes, and varicose zoster influence on immune mediation. So there can be a precursor that precipitates to this. And of course, you know, the main issue is, you know, what's happening at that blood-brain barrier, what is happening in relationship to, you know, the autonomic mediated and other immune mediated responses to inflammatory mediation in the body as well, and, you know, the cytokine and etc. going on. So tests, MRI, magnetic resonance imaging, spinal tap, spinal fusion, fluid analysis, evoked potential tests for multiple sclerosis, So you can get visually evoked potentials where they look at, the patient will look at a screen, looking at particular checkerboard patterns and seeing whether there's any particular discrepancy in the visual functionality of the eyes and the acuity of the eyes in relationship to that. Brainstem auditory evoked potentials, here a series of clicks in each ear to see whether there's any discrepancy left to right or any obvious indication of acoustic or insufficiency or deficiency going on. And sensory evoked potentials, they get short electric impulses and arms and legs and see whether there's any potential conductivity changes as a consequence of that. So that's one method in which they kind of like formulate diagnostic protocols for that too. So, you know, we have these categories, and my particular interest in, of course, is the relapsing remitting RMS type, because we have a higher incidence of that and prevalence in that in the cases that we typically see in clinic. Not always, but that's the kind of scenario that I've come across more frequently. Anyway, relapsing remitting RMS is characterized by clearly defined relapses, decreased activity, worsening of symptoms. They're following by remissions which the disease doesn't, where the disease doesn't progress. Symptoms may improve or disappear during remission. And then approximately 80% of patients are diagnosed with this type of onset. Untreated, about 50% of the RMS transition to recovery, progressive, so the next form with a decade of initial diagnosis. So we're going on to the next type. Primary progressive is diagnosed in about 10% of patients. People with primary progressive or steady progression disease with no clear relapse or remissions. The rate of this is equally divided between men and women. Symptoms usually begin between the age of 35 and 39. So I'm just going through standardized information on this. Progressive relapsing MS is the rarest form of MS, representing about 5% of MS patients have clear relapses combined with steady progressive of the disease. So again, you see the images there, the progressive charts illustrating the various presentations that we have. Okay, so again, nothing really new, but I want to now just go on to some aspects of, you know, what's happening in terms of, you know, the autonomic aspects of the nervous system and what things we have to consider when we're looking at addressing that autonomic functionality, and you know, how we potentially can influence it within the context of this neurological deficit, or obviously, you know, trying to establish optimization of the patient's constitution during treatment. And hopefully, you know, if we can do, as I have managed to do in a few cases, been to that situation where, you know, there hasn't yet always been the necessary for implementation of hard or very strong medication or at this particular stage. We will discuss that at a later date. But again, you know, we always treat within the context of safety and within the context of the patient's symptoms. And 9 times out of 10, as I am with other allied health professionals or other healthcare professional reference, the dialogue too, which is very important too, I find. So let's have a look at this. We're going to have a look at the actual parts of what's going on here, and how, you know, the autonomic nervous system has a hierarchy of integration. And this is important for us to consider, because when we're actually dealing with various components of viscera in relation and vascular aspects of things and various components of autonomic functionality, we have to pay attention to the fact that, you know, we are dealing with not just pure local regional tissue fields, but dealing with a whole aspect of the sensory afferent components of both sides of the autonomic nervous system. So this is very interesting when we particularly look at that too. So we have this kind of like integrational components, and the cerebral cortex and part of the limbic system actually produce behavioral components of autonomic responses over a full range of environmental changes. So, you know, it's higher centers that we're dealing with that deal with that kind of like final pathway that relates to also the emotive, but also the behavioral aspect of the body in terms of, you know, dealing with a particular autonomic stimulus. So that might be coming from, you know, just a temperature change through to change in taste, through to change in the exteroceptive or environment, that you're in, or in terms of the internal environment, the interior receptor side of things as well, remaining that homeostatic balance within the body. So all these parameters are very important, and there's like a hierarchy of control. Hypothalamus acts to produce an indicative behavioral, autonomic, and endocrine response over the full spectrum of physiological changes concerned with the survival of the individual. So that's basically what it's there for. It's dealing with, threat, dealing with potential of survival instincts. And of course, one of the first things that relates to is kind of like the primitive kind of like mammalian side of the brain, which, we take a food in, we smell, yeah, does it smell good? Taste it, does it taste good? No, it doesn't. So basically, no, we're not going to perceive it as a mechanism for use. So again, that whole hypothalamic function, the higher centers are integrating there. The reticular centers in the brain, such as the cardiac and respiratory centers, coordinate activities of individual organ systems. So this is an unconscious mechanism going on behind us. But, we can start to have a gentle, interest in that in terms of heart rate variability, for example, as my colleague Pascal's working on and looking at in terms of vagal function, vagal stimulation. How do we particularly relate to that in terms of the context of our work in osteopathy too, and having that potentially be interfaced in the treatment of our patients with MS, respiratory function, heart function, and other systems associated with that, the cardiovascular system. The next stage is preganglionic autonomic motor neurons modulate reflex autonomic activity in large segments of the body. So you see that number 4 going through. Number 5, postganglionic autonomic motor neurons integrate reflex activity in specific organs. And then, of course, we actually have the local neurons that produce interactivity on that visceral field too. So this is this hierarchy that we relate to in terms of autonomic integration. And that, relates to that sympathetic, parasympathetic side of things too. And it becomes very interesting when we start to look at, where our hands are interfacing. Are we working with that basic occiput? Are we working with that carotid sheath? Are we working with the infrasternal region in terms of the solar plexus, or the celiac mesenteric, or even the splanchnic aspect of things too? So this becomes quite interesting when we look at the modalities that we can address, or effectively address. And I want to have a look at that, some of the mechanisms behind that, because a lot of people say, yeah, that's very much a nice idea, but where's the proof? Where's the significance of that? How has it been evaluated? But, well, some aspects of it has, so I'm going to pull that up in a few bits of information soon. So I hope everybody's following me. As usual, I'm a bit fast, but few bits of information that are relevant to our work as usual. So again, we're looking at this particular aspect of sensory components. And quite often, when we look at our classical idea, we're looking at things presenting to themselves on the sensory side. And of course, this is a classic example of that, where we have sensory afferent, sensory autonomic components, visceral sensory, somatosensory, specialized sensory. So, again, in this little illustration that you see there, I don't think I can expand it. No, hang on, I'll come back again in one moment. Excuse me. I'm going to just stop that a second and come back, because it's gone funny. One moment. Where was I? Here. I think my slides have gone a bit funny already. Must be the heat. Go back. Okay, done that. Done that. Done that. Done that. Okay, done that. This becomes very interesting, and when we start looking at the effects of these various sensory afferents, we can see them. I'll go back again, I hope, without it going forwards too much. We're getting signals of drive autonomic activity may originate from viscera sensory side of things that you see, or vascular side of things. The surface of the body, somatic, somatosensory. So again, the nature of touch has a specific influence on that, and what we're doing with our hands has a specific influence on that. And of course, the external environment, the exterior receptive. So we have A, interior receptive coming from viscera, B, body surface, which is to do with tactile stimulus, and the environment that we're in, the exterior receptive aspect of things, which is the terms used today to describe these things. So let's continue with this. Again, sorry about that. We have our very simple, schematic here representing various components of the autonomic nervous system. And again, we're looking at both sides of that motoric aspect more, the autonomic motoric side. The sympathetic, parasympathetic have a specific role innervating specific target organs with particular receptors, and according to their respective pre or postganglionic fibers, have that very interesting, collection or and attribution of very specific functions that we always deal with and we're always considering in the context of treatment. And this illustration here just shows a few of those specific ganglion that are there under our skin, under our hands, under the skin, presenting themselves to us in respect to potential interface for treatment, within the context of indirect or direct treatment in relationship to inducing, an autonomic reflex of some form. So this is what we're going to go into in a while. So we get these kind of like scenarios that we have two types of sensory fibers, primary afferent fibers, and then we have, of course, various things that deal with cell bodies which result in the dorsal root ganglion and the sensory ganglia of the cranial nerves. The axons, primary afferent fibers carry information to the central nervous system. Then we have the enteric aspect of things, which is all to do with viscera, the cell bodies which reside in the enteric nervous system. Axons and enteric afferent fibers carry information to the sympathetic and prevertebral ganglion to mediate splanchnic reflexes. Now, the splanchnics are really interesting. Quite often in classical osteopathy, we talk about, hey, let's just address the splanchnics through various segmental centers. Very valuable, but in terms of inflammatory mediation, it's also very interesting too, and that correlates to what's happening with the vagus. So I'll pull a few little images of that up too, and that kind of starts to kind of like really kind of develop, involve, and expand on the potential of what we're doing within the context of our treatment. Quite often we're talking about that simple, context of, sympathetic atonia, parasympathetic atonia, balancing the autonomics through that particular hypothalamic connection. Motoric responses going on, but at the same time we're also dealing with very subtle cellular responses and quite often subtle immunomediated responses that are going on, and that's when it becomes very fascinating in terms of the context of addressing multiple sclerosis, for example, which is an autoimmune, as we know, an autoimmune mediated scenario, for want of a better term, condition. So we got this scenario, got these respective branches. We all have a, this is very simplistic, but we've got these gangliated chains. We have these specific nerves, and they all interface with specific functions. And this is great because we can kind of deal with that. And quite often, just in the context of our work, you'll have you do a leg rotation, or you'll do some kind of work on in the diaphragm or relation, and hey presto, we start getting visceral motility or expressing itself in terms of noise or in terms of temperature change in skin, or we might even get this dynamic where there's a change in the actual freedom of superficial tissue as a consequence of our intervention to various receptors that relate and pick up those specific organ function in terms of their associated plexi, for example, or ganglion. So this becomes very interesting. Let's continue. So here again, we have these specific type of neurotransmitters. This is just one group. There's far more complexities to this. There's lots of different derivations of these types. But again, if we look at that, we have specific roles, specific functions that can be involved. So, we're typically looking at, the respective segmental distribution, topographical distribution of those specific nerve innervations, and of course the sensory afferent side of those things too. So, specific relative to sympathetic stimulation or parasympathetic stimulation. Again, this is relatively simplistic, but it's good to have an idea of what particular fibers that are involved, which particular receptor types are involved, and the actual type of transmitter that might be going on there. So that's just one simple chart, but it's very interesting in terms of that functionality of adrenaline or epinephrine and various aspects of the acetylcholine receptors that are going on there. So just push that up, and that's our classic, first level autonomic chart that we can deal with and use. So again, we've got this idea that we have these particular functions, and we have these ideas also that there are particular branches and particular distribution points through which specific parts of the autonomic nervous system work. So again, we've got those that are respective to the dermal side of things, the skin, subcutaneous tissue in terms of vascularization, pilomotor function. We have those in terms of various activities of the lung, various aspects of the actual vascularization themselves, and of course, those ones that are specifically have specific functionality, like the adrenal cortex, for example, and an effect of the sympathetic. So again, the whole idea of this is that it's segmental distribution, somatotopographically represented, and this is the area again that, if we look at that little diagram at the bottom, which I don't think expands, but I'll come back again to it. You know, that is our segmental distribution of autonomic sympathetic relationships. And this, you know, when you go back to the charts that we relate to in terms of osteopathic centers, you know, this is the whole idea that is representation of vasomotor activity. I mean, some aspects of it relates directly to visceral motor because, you know, vasomotor influences the dynamics of viscera. You know, you can't have the fuel of the viscera without, you know, the viscera responding. So, you know, the role of artery is quite significant here. So again, the autonomic significance of that is wonderful. And of course, the hypothalamic relationship of that is always there and significant in terms of mediating the response according to the afferent side or the afferent motoric aspect of the autonomic demand, physiological demand, according to our environment, internally, externally, and of course, you know, cutaneously too. So, you know, this is wonderful. This is wonderful. All the components which we're dealing with day to day with our treatment. Okay, so let's go to this. One of the wonderful things that I love about the autonomic nervous system is that you have segmental distribution. And the wonderful thing about it is you kind of get this kind of like roadmap for addressing respective vascular beds, tissues, etc. And this is what I really love about the autonomic way in which things are segmented distributed, is that we have specific regions, specific chord levels, specific levels that overlap, but also have a significant influence in respective functionality. So, you know, when we're looking at, you know, now at this moment in time, you know, how do we interface with the brain? The brain is very, very much a topic of visceral and, you know, visceral cranial structure that we're dealing with. And, you know, one of the simple scenarios is, yeah, rule of artery, we're reliant on those vertebral artery innervations to provide good vascularization to the brainstem, and that has an influence on the dynamics of vascular nutrition to the to various vital components of the brainstem and the higher centers of the brain too, as well as other segments. So I'm just going to hopefully get this to zoom in, and then this is something that, you know, I really love. We have all these various, you know, this neuroaxis of autonomic innervation, sympathetics. And, you know, you just need to have that as a reference point for yourself when you're treating the patient, when you're doing the spinal oscillations. Think about, or any gentle, subtle mobilization of the segments in that particular field. They'll begin to influence the potential of those particular plexuses and their various segmental distributions and their segmental levels. So, you know, our role as osteopaths is to kind of like palpate, see what the tissue expression is in terms of the motoric representation of the autonomic nervous system, but also at the same time, you know, deal with the potential influence we have on those vascular beds. And this is just one diagram that is a representation of that. And the one down to the left, which I'll go back now, is also indicative of what's happening in terms of vascular activity, vessel activity, and the permeability of those tissues in relationship to the blood vessel, the cell types, and the migration of cell types into the interstitium. So we start looking at how we're influencing the extracellular matrix, intracellular matrix relationships, you know, connecting to fascia function, as I was discussing last week. You know, as soon as we start to influence the dynamics of the autonomics in terms of the vasomotor function, you know, the vasomotion, that influences that permeability, influences dynamics of the interstitial tissues that we're dealing with under our hands, and vice versa with venous as well, etc., etc. So that becomes, you know, one component of our autonomic interface, this general segmental distribution that we have. So I'll go through them again. Next one, of course, is that we have, you know, this particular cranial sacral idea, parasympathetic preganglionic motor neuron, and relationship to the sympathetics, hypothalamus, brainstem relationship, and of course our sacral outflow. So again, you know, this has a specific influence on, of course, the functionality of the enteric nervous system, the gut, and also, you know, production of various particular neurotransmitters, including serotonin, etc., that has an influence on inflammatory processes within the gut too, which is, again, another scenario that we can begin to consider and consider in terms of, you know, gut the interface of the gut microbiome environment that might be presenting in certain patients as well. And that, of course, is typical of the MS patient. Constipation, degrees of irritable bowel, sometimes, again, motility, retro propulsive activity of the gut quite often. You know, it's all there because there are changes in that, you know, autonomic and central innervation to the visceral structures that we're dealing with, which we'll talk about in a minute. So again, you know, this becomes more and more interesting to us. And again, the stuff that I'm talking to you is not neuroscience at a high level. It's kindergarten stuff, but at the same time, very relevant to what we're dealing with on a day-to-day basis. Okay, so here we have it. You know, you've got this sympathetic stimulation, what's happening, gut motility changes in one parameter to the other, gut secretion absorption, and gut vascular flow. So again, this whole component of autonomic innervation has specific influences. And we'll talk about that too, because in the enteric nervous system, it's fascinating how you will have sympathetic innervation straight to the central portion of that gut. And yet the parasympathetic innervation is only on that semi-peripheral region. And I'll show a nice illustration of that in a minute. And that is very interesting in relationship to the way in which the sensory afferent side of the autonomic nervous system, the sympathetics, pick up and deal with the mediation of toxic conditions in the gut, and also various mediators of inflammation on the gut lining as well. So that's very, very interesting stuff that we'll talk about in just a while. Okay, so again, you know, nothing new here. We have our friend the vagus, and you know, stuff that Pascal's doing, and we'll be talking about with our Italian groups, and you know, he's busy with talking about in Berlin in October, is all relating to this stuff. How does the vagal nerve relate to the mediation of autonomic modification or changes in functionality of autonomic balance or dysregulation? And this becomes fascinating. For us, we are looking at, you know, the ways in which we can potentially interface. And as you can see there, we have this wonderful innervation all the way through the heart, lung, diaphragm relationship to the neurogastric function aspect of it, all the way through down to the respective ileocecal region. And of course, then beyond that, we have the enteric component of it, but beyond that, we have the sacral innervations taking over, as you saw in that last diagram. So again, within the context of our treatment, you know, body adjustment, what are we doing? We're working with that baseline, we're working with that sacrum, we're working with that sacroiliac, we're dealing with those sacral outflow, but at the same time, we're mediating through that central group of segments, the sympathetic functionality, but also that that kind of transition zone of the homologous gray and white communicatives, where we have this transition between sympathetic and parasympathetics within that dorsal lumbar sacral region. So, you know, it becomes very interesting how we can component that. And if you look at that one illustration again on the right-hand side, we have that wonderful carotid vessel there, but we also have the carotid sheath, and through that carotid sheath, we have the potential for mechanotransductive influence with our hands to potentially have a role of influencing the vagal activity, and also sympathetic ganglion if we want to go into that field of things too, as everybody obviously knows, but just really cool. So this becomes very interesting, you know, what is happening at that basic occiput? What is happening in terms of those cranial foramina? If there is such a thing as you know, potential occlusion of it, is there more compressive effect going on in that basic occiput in terms of the suboccipital muscle groups, or is there some change in the vascularization of the carotid artery or the venous sinus components of things that are influencing the dynamics of the cranium too? But again, vagal, carotid sheath, recurrent laryngeal, all these various structures are very close to our hands, and something to consider when we're treating someone's neck. You know, what is the consequence of a mid-cervical adjustment? What are the consequences of an OA adjustment, and what is the consequence of a first rib and clavicle adjustment? You know, stellate ganglion, etc. You know, all these particular influences in terms of neurovascular compromise or whatever are there. So something for consideration. Okay, page missing, doesn't matter. I think we're going on to the next stage of things now. Yeah, so we're going to look at the case study now. Some of those things that we talked about already begin to directly relate to how we're addressing the autonomic aspects of MS, in particular in relation to the case study we're looking at. I'm just going to go through that with you. And, you know, now this patient that I'm treating is 60 years of age. When I first started treating her, she was 55, 56 years of age. And, you know, things are going quite well. And we're, you know, treating on a semi-regular basis, and she's developing her own motivational-based exercise routines. She's got a good discipline, not discipline, but no, it's not discipline-based. It's fun-based. A lot of the work that we're doing is trying to take away that label that's been given as a disease and actually turning the life or quality of life around and making things interesting and dealing with the condition in the context of lifestyle and ability and motivation. And this is one thing we've all been playing around with. So a lot of these various relationships are going on. This is a particular kind of like representation of symptom field that we've come across. Fatigue being one of the main issues, pain again being one of the main issues, muscle spasms being one of the main issues, and you know, this motoric activity also being a significant influence too. So here we are. These are the bubbles around which are things that are going on with some parameter dynamics of the profile of the patient you see now. So let's continue with that. So this is a typical scenario: left-sided hemiparesis, arm and leg, paravertebral rigidity, general really around the D5 down to L3 region, foot drop left untitled gait with compensatory vaulting, so she's like lifting as much as she can do with a circumduction type of movement of the leg, although that has actually improved over time. Peripheral muscle weakness, transient sensory loss, forearm and hands, infrasternal diaphragmatic and abdominal rigidity, but with prolonged constipation. But that is actually changing because she's been doing a lot of work with diaphragmatic exercise and working with lung excursion and actually encouraging that, you know, transient diaphragmatic stimulation of the upper gut. So that's been doing quite well in terms of facilitating motility, but also general function of the gut. So intermittent voiding bladder with hypertrophy and spasm. So some aspects of that we're kind of like dealing with, and we're actually providing quite a gentle influence on the voiding process and the volume of urine over time. So what we're working on, or I'm working on, or we're both working on, other patients that I'm seeing too, is trying to be in that situation within the parameters of relapsing, remitting scenarios where we can try and maintain a timeline that is, you know, relatively good. It's not getting shorter too much over time, and also dealing with all of these parameters within the context of treatment too. So it's really nice when we can start working with the bladder function, we can really start working with the diaphragm, etc. And we're going to talk about that in a while. And of course, you know, there's this intermittent visual and focal problems, both right and left eye, with, you know, intermittent optic neuritic scenarios going on quite often with a little bit of a flare up, or quite often post-infective. I've discovered that when there's been a scenario where there's been some kind of like other mediation that's triggered the immune response, bingo, everything starts to flare up again. And one example of that is when she stubbed her toe and had a nail bed infection, and unfortunately that kind of like created a little bit of a problem with that whole presenting scenario of the immune system triggering a systemic reaction to that. Low system resources. Oh dear, one moment. Hopefully my computer will not crash on you. One moment, let me see what I can do. Excuse me guys, I'm just going to go out of that and I'm going to get rid of that if I can. If I can. And I'm going to get rid of some of these things running in the background. Quit. Sorry about that, guys. And hopefully we can go back without being told that we've got a resource problem. And hopefully that's still there for you to see, everybody. Okay, let's continue. Yeah, we're 44 minutes into the timeline. So now we're looking at these various things. So what I'm going to do now is just go for a brief anatomical review of the autonomics and how, you know, effectively these are the areas and regions that we're considering and how we might interface with treatment in terms of the hands-on digital interface to, you know, have an influence on those sensory afferent nerves, or in terms of just pure muscular relaxation, and plus, you know, the whole idea of providing relaxation in the context of what is perceived by the nature of the treatment too. So that's also valuable in terms of the context of treatment, you know, the gentle application of treatment always. Okay, so we've got this scenario where we've got all these various components going on, in terms of presenting symptoms. And one thing we're dealing with is the visual scenarios, blurred vision, nystagmus, visual field defects, eye pain, etc. So, you know, one aspect of this that we can work with is gently working around the soft tissues around the eye, working gently with the orbicular iris muscle groups, maintaining, if we can do just gentle decompression and pressure around the orbit. So we're trying to provide, you know, that scenario where those vascular beds, lymphatic tissues are being drained and influenced by the work that we're doing. So, you know, this is the one thing that we're working with, and this is the point of innovation. Didn't that come up as a maximum one? Here it should have done. Should have zoomed in, but we can see there that we're particularly working with the relationship at the lower level of the cervical upper dorsal in terms of the sympathetic innervation, relationship to the vascular side of things, but also in relationship to the autonomic side of the ciliary ganglion, etc. And looking at the short ciliary nerves and how they influence the dynamics of the orbit of the eyes. So hopefully this will come up a little bit more, and you can see how that particular vasculature and innervation has a specific effect on acuity, on the dynamics of the interorbital pressure, etc., and how we can potentially influence that through indirect work around the base of the CD region, perhaps, and also, you know, that whole dynamic of general decongestion around the periorbital musculature and the lymphatic, retroorbital lymphatic side of things as well, if you need to. But very again within the context of gentle application. So again, you know, there we are. We have it. We have various components, and again, we have this scenario where we can begin to work very gently with various components of superficial tissue release, and then actually start to interface with those sensory afferents around the orbit of the eyes, the nose, etc., and the various branches that are involved as well. So that becomes very interesting, and this is something that we do as a gentle standardized application for people who have anything where there's congestion or discomfort around the eyes, dealing with that ear, nose, and throat, and, you know, facial and fascial drainage components of it. So again, you know, nothing new here for those that are familiar with this approach, but, you know, very valuable. And we're not working on providing too much pressure around the orbit, because we don't want to start to influencing too much on that cardiac reflex that happens with that orbital trigeminal stuff that goes on. So we have to deal very lightly within the context of the treatment there. And again, hopefully this will zoom in and you'll see a little bit more of the detail of the actual superficial tissues, but also the respective afferents components of that, of the autonomic components of the trigeminal and facial nerve, and various components there that we're interfacing with in the context of that too. Okay, so this is something I pushed in as well, because, you know, this comes under the dynamics of the lymphatics as well. So, you know, whenever we're dealing with various decongesting, we're also dealing with the relationship of our specific drainage components of the lymphatic system. And this is very interesting, because when we actually look at the way in which the actual continuity of the visceral cranium and the cranium becomes part of the component of the intercranial structures, those lymphatic pathways, which are glial lymphatic pathways, which have recently been discovered, are becoming very important in relationship to what we're doing within the context of our treatment too, because not only are we dealing with potential of drainage, but also flushing of neurotoxic components and amyloid structures, for example, but we're also dealing with the potential of changing the dynamics of lymphatic vasculature and intercranial vascular structures within the component of within the cranium, and how that influences the structures of the CNS too, and the origins of those vital centers for various components of the intercranium as well. So, you know, just looking at this particular slide, lymphatic vascular drains interstitial fluids which contain the tissue's waste products and ensures immunosurveillance of the tissues. Now, this is something that's also important, because immunosurveillance, a beautiful term, the immune system is constantly on kind of like standby, guarding and surveilling for various inflammatory components, or various, you know, toxic components that need to be dealt with. And, you know, this immunosurveillance is continuously going on a cellular level, on an interstitial level, as well as on a lymphatic vascular level. And, it's all components of what we're doing. And, it has a particular pathway involving the meningeal lymphatic vessels. And that is where we have this kind of like dynamic where compromise in that pathway begins to affect accumulation of various neurotoxin scenarios and accumulation of various byproducts of neurological metabolism. And that deals with changes in the neurolymphovascular aspect of things too. So I've got this paper. I'll give you this paper as a reference, and it's got these wonderful diagrams, which I'm just going to show you now. So here we have this, I hope it goes up. Yep. We have this wonderful image of the relationship of the vascularization and also the dynamics of the blood-brain barrier and how various components of endothelial activity can be influenced by the dynamics of what's going on a cellular level here. And the flow and the dynamics is very vital. So, the whole dynamic of venous drainage is very important to us. And also, the actual aspect of intracranial dynamics of vascularization as well. So this is one aspect of lymphatic clearance and blood-brain barrier transport that is always constantly going on, and we can potentially influence that. Quite frequently, it's more predominant at sleep, and also, believe it or not, in various positions of sleep as well. And that's very interesting too. And I'll give you a paper that relates to the lymphatics and that as well. So let's have a look. When we're looking at this and we're looking at the way in which clearance occurs, particularly in relationship to multiple sclerosis. Oh, come on. Didn't that not go back? I wanted this to zoom. I didn't zoom. I wanted it to zoom. But looking at that thing, potential involvement of meningeal lymphatic route on the CNS. Studies suggest that cervical lymph node has micromolecules that are drained from the CNS through different pathways, namely the lymphatic network associated with nasal mucosa. So that's very, very interesting. Cribriform plate. So that becomes very interesting in the context of our cranial work, if you want to have a look at that aspect of things too. Brown arrow. So you see that reference in that diagram there. And possibly the perivascular route, purple arrows. So we've got these other ones too. So paravascular routes. The cervical lymph nodes, along with the lungs, are closely involved in immune cell traffic and honing into the central nervous system, grey arrows, in autoimmune diseases such as multiple sclerosis, and participate in the generation of encapsulatogenetic immune cells. Whether the modulation of lymphatic drainage might attenuate antigen drainage and associate damage signals into the cervical lymph nodes and explore epiglottic spreading, hence decreasing in autoimmune response and prevent the current relapse in multiple sclerosis, is an important subject that needs to be addressed in future. And I will give you this paper. I pulled that illustration up. I know it's a bit overwhelming to the content. For me, it is a little bit, but it shows that, that there is this continuation of drainage. And this is why, again, body unity, we're dealing with lung capacity, lung efficiency, compliance, and this whole mechanism of that drainage continues beyond just the domain of the cranium and viscerocranial structures too. Okay, so let's look into this. We have this lymphatic scenario going on. We have the choroidal plexus creating some degree aspects of the CSF. We have venous drainage components. We have vascular components. And we have this very subtle interplay of filtering going on. And that glial lymphatic filtering system is something that we are beginning to utilize in treatment. And I hadn't considered it before I came across it 4 years ago because there wasn't much information about it. But no, within the context of the treatment I'm giving, in terms of cranial drainage, ear, nose, and throat, visceral, the anterior compartment of the body, everything, we'll go through that in a minute. It all has relevance to all of this stuff that we're doing in the context of treatment too. So, lymphatic continuum opportunities, osteopathic manipulative medicine, the brain has long thorough lack of lymphatic drainage system. Recent studies, however, show the presence of brain-wide paravascular system, approximately named the lymphatic system. So again, cerebral fluid and interstitial fluid are cleared through the lymphatic system, eventually drainage into the lymphatic vessels of the neck. This continuous fluid throughout offers a paradigm shift in osteopathic manipulative medicine. So, but the funny, ironic thing about this is when we've been looking at work on Little John and stuff like that in terms of the nature of headaches and the nature of toxins and stuff like that, one of the first things we deal with is the nature of that headache in terms of the component of whether it is vascular, venous, or CSF. And we don't exclude one or the other. We deal with it in the context of that, continuum. And that's, again, being emphasized in this literature today. So, it's really lovely to see it endorsing some of the stuff. And again, from this particular paper that is open, you can have access to, or you can view it online if you want. There are particular mechanisms in which we deal with various components of various aspects of venous drainage in the cranium, deal with arterial aspects of things, dealing with various lymphatic drainage, looking at the various ventricular function. And of course, we're looking at the functionality of improving drainage through, the excursion of the lung and the diaphragm too. So these continual mechanisms are there. And when we're looking within the context of our classical osteopathic cranial technique, cranial facial technique, quite often related to, this is something that, we're addressing within the context of treatment, on an everyday situation, really. And I think quite a lot of you out there is also doing the same. But it's nice to tie in all these kind of like modalities that we're using, and quite often people relate to, okay, ear, nose, and throat, but we're facilitating that mechanism for lymphatic drainage too, and it's lovely, and we're doing this vertex inhibition. We're doing that work where we're actually loosening up the superficial tissues and superficial lymphatic respective structures around under our hands there. And this is all dealing with that whole component of decongestion, working with the dynamics of lymphatics as well. Okay, let's continue. So we've got one component. Let's have a look at the autonomics. We're looking at the lung function. We talked about it recently, just now. Let's continue it. We have these specific, this thing is not zooming in. I wanted it to zoom in. It's supposed to zoom in. I'm sorry, folks. Let's go back. But we have that component. And I don't think it's going to zoom, is it? There's something going on with my laptop at the moment. Okay, I can't zoom in, but I'm going to go back. Come on, my little laptop here is almost dying on me. One moment, because it's very warm. Sorry, excuses. If you look at that illustration, you'll see that we have these wonderful autonomic innervations coming from the pulmonary plexus, from the phrenic nerve at certain segmental levels, and also from the actual, segmental levels of the thoracic area, pneumogastric, of course, of C345, influencing the dynamics of the bronchial dilation, vasodilation, and various components of, the capacity of lung functionality too, and of course the diaphragmatic components of things too. So one of the areas that we were, relating to also is mid-cervical. We're looking at the first and second rib. We're looking at the integrity of the costal vertebral junctions. We're looking at the integrity of the intercostalis. And, all these various mechanisms of treatment that we do with rib raising and various components of CD, cervical dorsal, and first rib and second rib decompression, various things, traction, etc. And, mobilization or suboccipital work can deal with that in terms of that too. And we interface that in relationship to sternocleidomastoid function, scalene, various things like that too. So, all within the domain of our arms and arm leverages, we're beginning to interface with that autonomic dynamic too. And that's excluding the tactile stimulus and the nature of the tactile fulcrum that we're giving at the same time. So again, working with that ventral relationship of the hyoid, dealing with opening up the respective trachea, releasing the sternocleidomastoid, carotid sheath, local hyoid traction, tracheal release, all providing a degree of freedom to optimize the relationships and the neurovascular relationships in relationship to the anterior region of the throat. So again, the nature of the interface is there within the context of the autonomic nervous system as well. And again, we can deal with our various components of leverage on the lung to facilitate the capacity, lung capacity, excursion, lung rib function, and etc. And of course, this becomes also part of the fascial domain too, in terms of various components of intercostal and neuromuscular fascial attachment. So we look at, for example, the Thomas Myers components of it as well, if you want to have a look at it in terms of the anterior, posterior, longitudinal components of meridians that they work with, or even the lateral ones that we talked about last week as well in my other webinar. So anyway, this is what we're doing. We're trying to provide increased compliance capacity, and at the same time, through our gentle application of tactile stimulus, we're relying on that dynamic of tissue release to provide general global dynamic restoration function. But of course, you know, there are parameters, lateral to medial components of the lungs that are we're facilitating. We're not necessarily reversing the effects, because, you know, plaques formation in various components of the spinal column will be there, but we're trying to optimize the environment that we have to facilitate that function. And that's what we're doing to facilitate all the mechanisms of aerobic physiology too, and the influence that that has on the cardiovascular system and everything else too. So, that one zoomed in now, didn't it, of course? So I'm having a few problems with my laptop here. And again, you know, thanks, Caroline, for these wonderful images that you have in your book. Again, the relationship of the first and second rib, and relationship to the apical suspensory structures, the fascia as well in relationship to that, and of course our inferior cervical relationship and the stellate ganglion, all, you know, within the domain that we're working with when we work with the first and second rib, work with the clavicle, work with the scalene, etc. So all these components that we're dealing with, like you do know, are part of the component of treatment within the context of that, you know, integrative aspect of treatment too. So again, you know, there we have it, and we can have the specific areas that we can work with: upper thoracic, mid, lower cervical, thoracic, sorry, and of course our flexion extension, the CD region relationships, you know, long lever, fulcrum relationships to the arm, and using arm on that first and second rib if we want to. So all modalities are all encouraging the dynamics of the movement in the thoracic spine, so the patient might be in a sitting mode at the end of treatment, or you might even do it in situ on the patient's sideline, or maybe supine or prone, or at the bedside, for example. So again, continuing through, we have these particular gastrointestinal scenarios going on with constipation and changes in mechanisms of mastication, chewing, dysphagia, upper lower GI tract decrease in absence, sphincter control, bowel incontinence, constipation. This is all the components that we can also address and encourage and facilitate within the parameters of the patient that we have, presenting condition or presenting symptoms that we have. So again, we're looking at these, you know, components within the autonomics are ventral plexi, one region that we can work with in terms of the context of that. Solar plexus and the relationship to the respective plexi that contributes to, and components, the mesenteric side of things as well. And that is and splanchnic, of course, which is very important there too. So again, this is where we're dealing with that whole connectivity of autonomic innervation to vascularization, also autonomic innervation in terms of various components of sensory side of the afferent side of the autonomics as well. And, you know, the nature of our pressure on that infrasternum relationship to the inferior superior cervical, the celiac ganglion has an influence on the respective motoric changes that we have. You know, and also, you know, the relationship of the suspensory structures in terms of that diaphragm acting like a, you know, an umbrella for the viscera too. So, you know, there's lots going on there. So here we have it in terms of vascularization, in terms of the respective mesenteric, supratheric, mesenteric, and splanchnic components as well. So yeah, these are the components that we can start to interface with in one way or the other. So again, going back to the classical text, we're quite often dealing with the fact that we provide inhibition to the celiac plexus and its communicating rami. Of course, we have lots of various plexuses, for example, that interface with that. So, you know, we have this typical idea of releasing abdominal tone, diaphragmatic release, but at the same time, we're reinforcing the carefully graded pressures applied within the confines of the costal arch in a limited clockwise direction and in unison with expiration. The reduction of tension is useful palliative measure, playing an important part of modification of sympathetic response. So again, we're addressing that sympathetic aspect of things for the ventral rami, the ventral components of the plexus is there. And again, you know, this is something that is subject to research for validation purposes as well, I believe. And there's some material out there dealing with that, and I will include some of it as well. So there we have it. I'm going on a bit. I hope everybody's still with us. Again, we're having this scenario where we're dealing with the component of various aspects of various plexuses, in terms of ventral side, the hypogastric plexus, providing flexion to a disengaged ventral muscle activity, and providing freedom of tissue, and dealing with various gentle pressure, inhibitory pressure to facilitate functionality within the hypogastric domain. So showing the full flexion together with depth of range of extended ventral pressure. So this is something I quite often do with my arms, hands underneath the legs flexed, bring flexion up, and actually working with my hand in relationship to this respective plexi, but also suspensory structures of the ascending and descending paracolic structures there too, as we're working. So that's also valuable within the context of our treatment. Okay, so here we have it. And again, we're looking at the relative potential splanchnic gastrointestinal irritation. So that, again, is quite often under the idea of inflammatory response that's going on there. So I'm going to talk about that as well in a minute. Showing the knees in full flexion. Let's go on, go on. So again, we're beginning to continue with this idea. And I just want to get back down to that. My other image. Where are we? Sorry guys, wait a minute. So, I'm trying to kind of like give some validation behind components of our work, and, how this interfaces with various other, papers and articles that relate to some aspects of this too. And, neurological interactions of gut and the significance of intestinal immunity, this is something that is significant today, and we're really interested in the field of microbiome activity as well, and what's happening in that gut environment. And of course, the nature of that gut environment is very important to us. What is happening in terms of the mucus activity there, what's happening in terms of the environment of those various lumen structures that we're dealing with. And that becomes very fascinating when we look at the actual aspect of the microbiomes and colonies of various biomes that are involved with that component too. But this is dealing with more to do with the significance of inflammatory responses going on here. So, it didn't. Okay, that went up. So this is a nice illustration, again, showing the significance of the splanchnic nerve and the correlation of the vagal nerve to the splanchnic. Schematic overview of the existing theories on the cholinergic anti-inflammatory pathway. So this is very interesting, that the splanchnic in relationship to vagal function has this potential of reducing an anti-inflammatory pathway. The theory of cholinergic anti-inflammatory pathway calls for the efferent fibers to suppress inflammation via splanchnic nerve bundles. The nerve bundles that innervate the spleen are sympathetic in nature, although the cholinergic innervation of the superior pole of the murine spleen was also described via a apical nerve. Right. Figure 2, I'll talk about this in a moment. We've got an image in a minute. It displays how the splenic nerve can influence immune cells. It's hypothesized that vagal fibers and splenic nerves synapse in the celiac ganglion. However, thus far, anatomical studies have not established this. An alternative theory assumes that the greater splenic nerves comprise the anti-inflammatory pathway. Both sympathetic and cholinergic nerves innervate the large intestines, while the distal part of them receive innervation from the sympathetic nerves that originate from the sacrum. So this becomes very interesting in terms of autonomic anatomical topographic relationship, and how the splenic activity is being actively a component of inflammatory mediation here, as well as vagal, of course. So here we have the diagram. Let's hope it enlarges. Yes, it does. We have particular factors being involved here. Splenic nerve involved in various components of inflammation. Stimulation of the splenic nerve causes the release of norepinephrine, which binds in receptors on the choline acetyl side of things. So again, I'm not a neurobiologist or so forth, but this becomes very fascinating when we think of the various components of what we're treating. And when you look at the old classical text, they talk about splenic innervation going on. This is the neurophysiology and pathological mechanism behind that, I believe. And this is how we can actually innovate and influence it through splenic innervation, one way or the other. And this is where it becomes very interesting. If you look at the active innervation of vagal efferents and sympathetic efferents, you discover, yeah.
Some people have to leave
Oh, that's okay.
time. It's just that I send you a question.
Oh, right, I didn't see it.
Question though. Sorry to interrupt.
No.
Some people have to leave, and there was a question from Mervyn Wallman.
Yeah. Oh, Mervyn was there, was he? Oh, great. Yeah.
Interesting question. So you want to answer that? Maybe he has to leave.
Yeah.
Thank you.
What is the question? I can't see it actually. I can't see it actually on my screen.
I send you in your question box.
Where is the question box? One moment. I seem to have I have a very non-responsive mouse at the moment for some apparent reason. Question box. One moment. Oh, it's quite a few. One moment. Where is my mouse? Where? Right. I'm going to just escape this. Now I'm going to go and try and find it. Where is my Q&A? Q&A. Sorry, guys. Q&A. How can we ensure that a manual treatment may not trigger or worsen? Yeah. Well, this is what we have to be very careful of in terms of initiating too much irritation. This is why we have to be able to kind of like monitor our patient and actually leave them well alone when there's this flare up, and monitor. And if possible, like a few of my patients are doing, are actually providing a little journal. Give me indications of what particular symptom patterns that were becoming flared. And then once that flare up has gone, begin to then start to gently and subtly address that within the context of the treatment and maybe deal with the consequence of that flare up. So there might be a scenario where there is sensitivity around the eyes, but not when there has been a flare up. So, you know, what I'm actually doing at the moment, believe it or not, is I'm actually getting kind of almost some aspects of data from my patients on a real-time basis. This is what I'm doing. I'm working with parameters of constipation and inflammation that are based on various standard outcome measures that can be, the patient can observe themselves or their assistant or whoever's with them, if needed be, can be implemented. And also some aspects of motoric and also nociceptive aspects of things too. So there's particular scales that we use that can like give me information, and that gives me feedback on how the patients are doing anyway. And I've got a system underway where I'm doing that on a remote sensing method. And I'm beginning to get feedback from the patients, and I can begin to start looking at particular patterns in the context of that patient. And I'm using machine learning to actually assist me with that process as well and look for particular trends. So this is something I'm playing around with on the side. But going back to that, yeah, I'm running way over time. I'm always doing that. But never mind. It's a scenario of being able to work within the confines of the patient at that time, basically not working at the time when there's a flare-up, just basically palliatively working, trying to reduce sensitivity if necessary at that particular time, and maybe deferring treatment for 10 days or so and getting feedback from the patient based on that as well. Okay, so hopefully that answers the question. Treating, you might begin to just palliate with just some aspects of things, but you have to be very aware of an immune system. Immune response is one of the main things that deals with that in terms of quite often the eyes, and quite often in terms of certain components of digestive function, raised sensitivity, and various other aspects of that too that we keep an eye on. So hopefully that's given some feedback to
that question from Mervyn was he was asking, he is given this illness is a major destruction of nerve conduction. In the remission and relapse of there is a remission and relapse cycle. So how can we show with the manual treatment
Mm-hmm.
we are not triggering or making worse these symptoms? That was the question that Tim just asked.
Yeah. Well, within the context of what you're doing, you have to work within the confinements of the patient, and also, you're relying on monitoring that patient on almost a daily basis. If not, I have a situation where I have a little app that I've set up where patients give me feedback as to how they're feeling prior to and after treatment, and in particular to their specific symptom patterns that relate to their condition. So I have that fortunate scenario where I'm getting that kind of real-time feedback given to me. But at the same time, we don't want to exasperate symptoms, and we're looking at trying to be in a situation where we can work within the context of what the patient can receive in treatment, and not over-treat and not oversubscribe treatment at the same time. In some cases, I'll be working once every 10 days, once every 2 weeks, or once every 3 weeks, depending on various parameters that the patient gives me. And again, within the context of the question given, we have to be careful that we're not actually worsening symptoms. And in the experience of my work so far, I haven't been in a situation that I have worsened their symptoms. Other interventions have, which have been more neuromuscular based. Other interventions have when there has been a scenario of opportunist infection as a consequence of various skin traumas, things like that have happened as a consequence of injuries at the home, etc. So they have been not incidental, but have been contributing, but not necessarily as a consequence of my intervention. And my intervention is measured and weighed on feedback on a continual level. So, I'm running over time, but dealing with the actual management of outcome measures, looking at the degree of various components that give physiological values that we can address. And one of them is quite often just pain values, but also the efficiency of movement, but also sleep duration, things like that. And also, sensitivity to various things, from bright light to humidity, all these exteroceptive kind of like stimuli that are involved with this. So yeah, it's a part of what we're doing.
There is another question, you don't mind?
Yeah, no worries.
They're asking, are there any methods for getting access to the autonomic reflexes as a loop for improved motor output?
Well, yes. I mean, the thing is that what I have been doing is working with a very similar model that Lederman has been working with, and I will throw that up because it's just here, and I will play it if I can get it, where I have been working at addressing various components of that in terms of rehabilitation rather than rehabilitation, where I'm actually getting the patient to work within a certain domain of movement and encouraging various motoric reflexes and fine motor reflexes to be encouraged through that phenomenon known as neuroplasticity. And there's various ways in which you can evaluate that in terms of functional MRI, functional MRI, but also qualitative EEG analysis. And that's something else that comes under the parameters of addressing the treatment outcome. And, unfortunately, I've run over time, and the content of this material is, quite comprehensive. But this becomes very interesting when you're looking at the dynamics of neuromotor rehabilitation rather than rehabilitation. You're providing an environment where the patient can provide a exercise routine that they can address and they can modify according to their ability on a daily basis. And this is what I've been working with a few of my patients, where they are actually actively involved with motivational based exercise, where they see the good outcome of it. And it's not task based, it's more based on their ability. And from day to day, according to how they're feeling, they work out and develop a routine and method of treatment that is developing motoric function as well. So hopefully that's answered that. And it involves that component of motoric development of gross and fine motoric skill. And an example of that, which I'll show you, is this one, which I'll throw in now and just show you, that she has developed herself. And you will see where she's using a ball to provide adductor muscle and also ankle eversion and eversion mobility. Sorry, the computer is getting too hot. But basically, that is providing a mechanism of stability, developing with abdominal muscle groups, adductor muscle groups, but also she starts with fine motor control around the smaller ball with her ankle. And her weak leg is the left one. And quite often, if necessary, she will support the leg to begin with, but quite often she can utilize that as a mechanism. And that is a graded exercise which she has developed according to her everyday means. Another one that she does is, if you look at the level, the diagram to your left-hand side on the bottom, she actually starts to work with her relator with a movement of almost dancing type of movement, which she does, which kind of like creates muscle, what is it called? Muscle recruitment, motoric recruitment, and it's based on various exercises. And the funny thing is that, you know, there's a difference between aerobic and anaerobic exercise, and the forced aerobic exercise, although within moderation, actually has been proved to improve the quality of motoric activity in the body over time. So that's also been kind of like reviewed too. So anyway, yeah, I'm sorry everybody that's gone over time, but within the context of what we're doing, you know, there's a lot of parameters within our work that we're dealing with in the field of the autonomics. And again, you know, I'm working effectively with the whole idea of eventually evaluating this method of approach, which is implementing gastric side of things, constipation, dealing with the renal aspect of things in terms of the functionality and plasticity of the bladder. I'm also looking at respiratory function. I'm also looking at visual acuity. I'm looking at cognitive function. I'm looking at, I mean, it's a lot of parameters to involve all at once, but, you know, there has been standardized research in some of these fields already. But, you know, for me, I want to be in a situation at the moment. I have got 14 or so patients that are all at the moment being subsidized, divided into different categories associated with their symptom presentation and their treatment needs. And one of the things has been working with the Bristol poop chart, dealing with the consistency of fecal material and how that relates to the gastric function. Another one is dealing with just the volumetrics of the bladder function in terms of volume, but also actually the analysis of any indications of change in inflammatory markers in the urine as well. So that's indicating how maybe the general baseline of inflammatory response is going on. And there's other parameters too. So, you know, this is what I wanted to try and cover. And obviously I've gone over time far too much, but hopefully this is giving you an interest into the dynamics of where we can start to address this condition as a multidisciplinary approach, which, you know, lies within the context of what we're doing within the body adjustment. And, you know, it's a modification if necessary, but within the abilities and within the parameters of the symptom patterns and the patient's constitution at the time, which is variable, you know. And yes, you have to be careful not to exacerbate symptoms, but, you know, you get to a scenario where you provide a level according to each individual, and you know, monitor those symptom patterns very carefully. And this is what I'm working on with this component at this moment. And you know, I get motoric feedback based on sensors for two of my patients at the moment. I have feedback on general bowel function from a simple app that just looks at the Bristol pool functionality. I've got, you know, various parameters of urine volume analysis from patients that are just giving me, you know, through their care assistant values. So, you know, I'm just looking at various components of addressing ways in which I can begin to address outcome measures, standardized outcome measures for these things as well. So yeah, I've run over time. You know me, I always do that. But there's lots of stuff. that are involved. And what I do is I'll put up a resource page where you can have the essential material on this. Plus, I will also include some very interesting research that relates to various aspects of inflammatory mediation, MS, various components of addressing the psychosocial aspects of things as well, in terms of mediation, helping the quality of life values in the patient too. Okay, so perhaps, with that in mind, if there's not too many people still around, I will stop. But if people want to stay and hang on for a bit more, I can zip through this feed. It's up to them.
Someone was asking if you work along with some nutritionist or.
Oh yeah. The nutritional aspect of it is one aspect that is very valuable, and it's one component where there's trying to get a balance between a good balance of vegetable-based intake, reducing processed foods as much as possible, trying to moderate intake of natural fats, especially animal fats, etc. But at the same time, allowing for the fact that, that the function of the nervous system is reliant on that fatty Schwann cell activity. So you want to have a state where you're dealing with the balance of dietary function too. But at the same time, my argument in the scenario is when you're dealing with dietary aspects of things, if you've got someone that's constipated and can't eliminate things, you're going to get a toxic scenario anyway. If you can facilitate detoxification through bowel function, and then you can actually facilitate assimilation of nutrients through good gut function, then that's something that we're trying to deal with as well, and reducing that inflammatory response, and also dealing with the parameters of the microbiome and bacterial consistency also has a profound effect on this too. So what I will do is I will leave this information for you to look at and see how this correlates to MS. And all these parameters that I will put down onto a website within the next 2 days will deal and be involved with what I'm doing and working with within my small patient group that I'm dealing with at the moment, with a view to continuing that research and hopefully doing a cohort study where I can look at various parameters and do a treatment approach with slight variables that can change, and see what we can do in terms of the nature of the relapsing remitting episodes and the quality of life value of the patients as well. So that's the ultimate aim at the end of the day. So yeah, there's a bit too much information probably, but it's very interesting when you look at the neuroanatomy and the autonomic nervous system. That's one component of it all, but every tissue that is part of the body has some innervation of some form, and that's working also on a ESM, ECM, extracellular matrix, on a cellular matrix level, on a tissue level, on a receptor level. And if we can provide an environment, whatever that may be, to enhance that functionality in whatever way that may be, then we can do. And the work that we do within the context of the GBA is one tool for that, I believe. Okay.
Okay,
All right.
Thank you very much.
So,
very interesting subject.
I shall leave it at that, I think, and people can look at the material in their own time. I will put some aspects of it up.
We have recorded this webinar, so it will be in the Vimeo account. And just say thank you to everyone who was logging in. Yeah,
apologies for overrunning, but it's a big subject, and there's lots of potential. And as I say, I'll leave it to you. Look at.
We can do one every 1 or 2 years, and there will be more news and research.
Yeah, well, maybe we do part 2 of this. This might be an idea to do part 2 of this within the context of actual treatment and the neuroanatomy behind the autonomics as well, the autonomics in application. Okay. Thanks everybody for listening.
To everyone who was here, is that if you want more information about the Institute of Classical Osteopathy, you can check our website. We have a new course coming up in September, the foundation course. So thank you for listening. Thank you, Tim. Have a great summer, everybody. I hope it cools down a little bit.
Yeah, hopefully so too.
Okay.
Okay. Well.